Good afternoon, everyone. Today's webinar is about suicide prevention in American Indian and Alaska Native communities. My name is Puneet Sahota, and I'm the Research Director at the National Indian Child Welfare Association. This webinar is being hosted by NICWA, the National Indian Child Welfare Association, and we are a partner in the National TA Network for Children's Behavioral Health, which is operated by and coordinated through the University of Maryland. The objectives of today's presentation are to understand how to talk about suicide, to be able to identify warning signs of suicidality, to identify strategies for postvention, which means strategies for preventing further suicides after one has occurred, and to learn how to develop a community plan using safe messaging to respond to suicide and to prevent suicide contagion. So just to begin and talk about the scope of the problem, research has shown that American Indians and Alaska Natives, sorry, can we go back to slide 4, please? There we go. So American Indians and Alaska Natives ages 15 to 24 have the highest suicide rates of any subgroup in the United States. It's 3 to 4 times higher than for any other U.S. youth group. Suicide is the second leading cause of death for American Indian and Alaska Natives in this age group, and almost 15% of high school Native youth reported a suicide attempt in the past 12 months, which is nearly 2 to 3 times the rate of other U.S. youth. So when we think about suicide prevention, the literature and also in practice, most of the work is based on the medical model. And so the idea of the medical model is that if we ask questions, screening for signs of suicidal thoughts, or screen for risk factors, hopefully we can identify young people at risk and then try to prevent suicide. So a lot of the screening for suicide in the medical model is based in healthcare settings like clinics and emergency departments. And there are different programs in various hospitals, coaching healthcare staff to ask questions related to thoughts of suicide. And there's also some research showing that these kinds of screenings and brief interventions in the emergency setting can help. And so one study that was done in a Native community, small sample size, showed that after ER visits, a brief intervention to help improve mood and cognition among youth with suicide did actually, have that improvement. The study wasn't long enough to assess whether there were actual decreases in the rate of suicide across the community and didn't have a large enough sample size, but it did show that both mood and cognitions, which mean thoughts, got better among youth that were in the ER with thoughts of suicide and who then received this brief intervention. The challenge with the medical model is that it can miss youth who may not even come in to a health clinic. And so there may be young people in a community that are having thoughts of suicide, but who are not seeking medical attention or health attention. And so we may miss them. The medical model also addresses the risk of suicide in people already identified at risk. So if we look at the research within suicide prevention in clinics, it's about figuring out which subgroups of people could be at risk, such as people with certain mental health diagnoses, and then how do we help reduce the risk in those individuals. That's kind of how the medical model works. But if we did community-based screening or community-based strategies that involve the entire community, that go outside the clinic, outside the hospital setting, we might be able to pick up more youth at risk for suicide and to also help prevent suicide. Suicide contagion is a term used in the field when we talk about one individual having completed suicide and then the risk of suicide in people who were close to the person that died. And so suicide contagion is when multiple suicides happen within a social network of people. So community-based strategies can also help to prevent suicide contagion. So Suicide contagion can occur when others in the community feel so overwhelmed by emotions after a suicide that then those survivors also attempt suicide. A suicide cluster is when a group of suicides or attempts happen close together in a time frame within a community. And teens and young adults are the most at risk for suicide clusters. Survivors of a traumatic death, like an accident, are also at risk. So when we think about preventing suicide contagion, we really focus on the survivors of suicide as they are the group that is at highest risk for attempting suicide. So how do we create these community-based strategies? First, literature and best practice shows that creating a community-wide plan involves collaboration between healthcare systems and other departments within a community. And so within tribal communities, that could include emergency medical responders, police, schools, cultural leaders, spiritual leaders, cultural centers, recreation centers, all those kinds of parts of the community can come together with a healthcare system to create a community-wide plan. Some tribal communities have convened a suicide prevention task force, which is a community board that brings together staff or leaders in these different areas that I was just mentioning: schools, police, emergency medical responders, healthcare, spiritual leaders, cultural leaders, and so on. So that kind of approach can be one way to implement a community-wide plan. Another community-based strategy is to expand positive activities for youth, including boys and girls clubs, youth centers, and cultural activities. And what we've learned working at NICWA with communities over the years, and also in talking with tribes about what works, is that including spiritual or cultural components is critical in any suicide prevention program. So those are some of the aspects of, community level prevention. But then we also, need to consider what we as human service professionals and people in the caretaking professions, what we can do in our individual interactions with clients to help prevent suicide. And so in many communities, there is a silence around thoughts of suicide, and people are afraid to talk about it. And these are some of the specific barriers that the literature has in it, the research literature has in it, like reasons why people don't talk about it. Some of it's politeness. People worry about offending or embarrassing someone, and that can be a barrier to asking directly about thoughts of suicide. Religious or spiritual beliefs around suicide being a sin can also be a barrier to talking about it. Stigma around suicide or mental health in general can prevent youth from seeking help. And so one of the myths that, is related to all this is the thought that if we talk about suicide, it might plant the seed and make somebody who wasn't considering it suddenly start considering it. But in fact, the research evidence shows the opposite, which is that talking about suicide or asking a youth about suicide is more likely to help that youth feel cared for and feel less isolated. There's not an increase in suicidality for youth who participate in suicide prevention education programs. Of course, it's important to note that different communities have different cultural conventions around how to talk about sensitive issues like suicide. So specific strategies for how to break this silence are going to be different in different communities. So for tribal communities, respecting cultural protocols is important. There may be cultural and spiritual beliefs around who and with whom these kinds of conversations can take place. And those values and beliefs certainly need to be respected and put forefront when, planning these kinds of conversations. It can be helpful to ask permission from the community, elders, leadership, and those who are survivors of suicide or those who have lost a loved one before starting these kinds of conversations. We definitely recommend that any community gatherings that address suicide as a topic should include counselors, traditional healers, and elders who can be there to process and debrief emotions. Because, even though it might be a suicide prevention training, community members who have lost a loved one to suicide may have grief or trauma reactions that are triggered. And so it is important in those kinds of trainings to have, helpers available for debriefing. So what are some warning signs that may, tell us a young person is at risk for suicide? These are some of them: talking about wanting to hurt or kill oneself, looking for ways to kill oneself by seeking access to firearms, pills, or other means, talking or writing about death, dying, or suicide when those actions are out of the ordinary or not really characteristic of that person, feeling hopeless, feeling rage, uncontrolled anger, or seeking revenge, acting reckless or engaging in risky activities. Other warning signs include feeling trapped, like there's no way out, engaging in substance use, like using alcohol or drugs, withdrawing from friends, family, and society, feeling anxious, agitated, unable to sleep, or sleeping all the time, having mood swings or dramatic mood changes, and not really feeling like they have a reason for living, or feeling like they don't have purpose or meaning in their life. So when we talk about postvention, what this is referring to is, again, preventing suicides from happening in a community where a suicide has occurred already. So it's trying to prevent that suicide contagion. And one of the key principles of postvention is that everyone who's affected should be considered a survivor of suicide. So, for example, if it was a youth that died by suicide, then other youth in their peer group, their family, friends, adults in contact with the youth, like teachers, all of those people should be considered survivors of that suicide when we're considering postvention. So as a helping professional working with survivors of suicide, some of the things we recommend are to really accept the intensity of their grief, to show compassion and to avoid simplistic explanations, and to know that suicide grief is unique, and to be aware of holidays and anniversaries, to be able to refer to support groups, and to also honor faith and spirituality as a source of resilience. So some helpful things to say or do for a survivor of suicide include, I'm very sorry, my heart goes out to you, to be supportive and be a good listener, to just be there for them, and let them talk about their loved one without passing any judgment, and know that people are going to grieve, especially from a sudden and unexpected death like suicide. People will grieve for that loved one in their own timeline and in their own way, and that's not always predictable. And so it may take longer or, be a different process than other kinds of grief. Statements to avoid saying when providing support are, it was his or her time, he or she is in a much better place now, you have to get over this, and I know how you feel. Really the point here is just that suicide grief is individual to the person who's the survivor, and it's important not to minimize that grief, by saying things like, he or she is in a much better place, or to try to encourage them to get over it. In fact, we need to just honor whatever their timeline and process is. And giving good support to survivors of suicide is helpful in preventing their own mental health issues from decompensating or preventing them from having thoughts of suicide themselves. And that's why, what we say and the language we use is so important. So community-based plans for suicide prevention, the SAMHSA guide for tribes for suicide prevention has some of these key bullet points. That a community-based plan should involve all concerned parts of the community, should involve elders, spiritual and cultural leaders, be coordinated by a committee and host agency, for example, a mental health agency, should be put into place once a suicide or traumatic death happens. So that should sort of trigger the community plan to be implemented. It should involve contacting and mobilizing groups that will play key roles in preventing suicide contagion. Should avoid glorification of suicide victims and try to minimize sensationalism. include a timely flow of accurate and appropriate information for the media. And I'll talk a little bit more about media-specific considerations here in a moment. And then community-based plans to prevent suicide contagion should also identify individuals that are at high risk for suicide. For example, those who were close to the person who died, and to refer them to mental health services if needed. So some recommendations for the media, and when we say media, this certainly includes national media, but it can also be local media, like a community radio station or a community news, a newspaper. The way that suicide is portrayed in the media is very important to consider in preventing contagion. Research has shown that when a suicide is widely reported on in the media in that geographic area, the rates of suicide go up just a little bit. And so media coverage can be triggering for people who may already be having thoughts of suicide to act on those thoughts. So what are some recommendations for the media when we're looking at suicide prevention? First, don't portray the suicide as a romantic or a heroic act, because that may encourage others to identify with the victim. Don't detail the specific method used in the suicide. Don't publish photos or detailed descriptions of the suicide. Don't use youth in the media and ask them to tell stories of their suicide attempts. Don't dramatize the impact with pictures or descriptions of grieving relatives, teachers, or friends. And don't use the word suicide in the headline. Recommendations for what the media can do are to refer to a rise in suicide rates rather than a suicide epidemic, which is sort of a more sensationalized or dramatizing language. Refer to a suicide in the body of the article, not in the headline. Describe the person who's died as having died by suicide rather than using language like committed suicide. Sorry, just trying to go back a slide here. And we also recommend using language like non-fatal attempts instead of unsuccessful or failed attempts, because that implies that completing suicide is a success, and we don't want to have that connotation, especially for young people who may be reading these kinds of media reports. So other messaging considerations, of course, people don't just get their information from the media. Social media is a huge source, if not the primary source of information for many people, especially when it comes to a local community. So what are things that we can recommend to our clients, to our colleagues, as far as their messaging on social media? These are some guidelines for safe messaging. We recommend avoiding detailed descriptions of the suicide. We recommend avoiding romanticizing somebody who's died by suicide on social media like Facebook. We recommend avoiding first-person accounts from youth about their own suicide attempts, avoiding glamorizing the suicide of a celebrity. We also recommend avoiding oversimplification of the causes of suicides, murder-suicides, or suicide pacts, and avoid presenting them as, unexplainable or unavoidable, because that implies they weren't preventable. And we want people to have hope, and we want people to feel like it is possible to prevent suicide. We definitely do not recommend overstating the frequency of suicide. And then I've already kind of mentioned why we recommend language like someone completed suicide or died by suicide instead of language like they committed suicide or they had a failed or unsuccessful or successful suicide attempt, because we never want to imply that a suicide is a success. What are best practices in safe messaging on social media, like blog posts or Facebook posts? We always recommend including a referral phone number and information about local crisis intervention service. We recommend emphasizing hope and recent advances in treatment for depression and other mental health issues, just to let people know that there is hope that they'll feel better. We want to include stories of positive stories of people whose treatment was life-saving, or people who overcame their despair without attempting suicide. Another strategy for safe messaging, either in news media or local social media, is to interview a mental health professional who's knowledgeable about suicide and the role of treatment or screening for mental disorders as a prevention strategy. We also recommend, again, just emphasizing the positive side of things like the decreasing trends in national suicide rates and focusing on what communities can do so they feel empowered in terms of how they can prevent suicide. We also recommend, reporting on activities that are coordinated by local or state suicide prevention coalitions as another helpful strategy. So when a suicide does occur in a community, we recommend that one person be the point of contact for all media, and that contact person, can advise local media on how to report about suicide in terms of best practices for preventing further suicides. And that media contact can also provide information for counseling resources to include in any media reports. The point of contact person can also coordinate with the tribe's media contact and work to protect family and other survivors of the person who died by suicide from reporters. And of course, as we've already said, we recommend avoiding footage or photos of the family, community members, or peers, because that can contribute to the risk of repeated suicides. So these are some links to resources from SAMHSA regarding suicide prevention. We hope that you find those helpful. And then these are the references that were cited in today's presentation. If anyone has questions or feedback, we would be happy to hear from you. This is my contact information as well as SAMHSA's number as well. Thank you for your attention today, and hope that this webinar was helpful to you. Thank you.